cost of translation services for 2021 and 2022, and collectively it was over £100 million, which could pay for 3,000 nurses.
Abby, over 100 million. Let me put another point to that. That's the direct cost. How many times do the translators not turn up?
It has to be cancelled. Management in the NHS right now, like, are they resistant to change, or are they happy with their way of working? Because that, to me, in my research, comes as the #1 issue, the bureaucratic bottlenecks.
Yeah.
When it comes to pathway change.
To run the NHS as a whole is a mammoth organisation. It's one of the largest in the world, right? So you can't operate a system like this without complexity. Can we quickly make the changes, and what is the new world should look like?
Yeah.
So by all means, dismantle current system, but dismantling current system without absolutely being clear what are we trying to achieve and how long it's going to take us to see then positive impact on patients.
We need to just put this aside and try and see that, look, nobody's happy, but everybody wants to be happy, and this is a solution.
Yeah.
So you can cry about it, or you can complain about it, or you can do something about it.
If you structure it well, you could reduce the cost of delivery, you could improve patient outcome, and most importantly, patient satisfaction.
Wow. My guest today is someone at the cutting edge of healthcare innovation and strategy. Ray Guirgis is the director at Rapha Health Consulting, where he leads the delivery of medical, surgical, and dental advisory services across the UK. With over 5 years of experience in this role, Ray is pioneering the use of AI-powered technology with Axonic Health to drive efficiency and demand generation in clinical services. He's held leadership roles at Future Life and OSD Healthcare, and currently advises several growing healthcare organizations, including VSS Dental and MediHealth. With an MBA from Bayes Business School, a master's in pharmacy, and further training from Harvard Medical School and London Business School, Ray brings a wealth of strategic insight and passion for enhancing patient outcomes through innovation. Ray, welcome to Dose of Health.
Thank you very much, Abhishek, and thank you for inviting me.
Is this your first time on a live podcast?
Yeah.
Oh, wow. I feel honored.
The honor is all mine, and the editing is all yours.
Okay, I want to start from patient journey in the NHS. Okay, so it seems like to me that on paper it all looks efficient, right? You get some illness and then you go to the GP, and GP then does referral, diagnostic, treatment, but the reality is different, right? So you've worked in the NHS. In your experience, what kind of delays and frustrations do you see patients facing most often in their journey?
I think it goes without saying. I think everyone in the UK can see waiting lists as a main problem, and is the biggest sign to everyone that there are cracks in the system. Talking about the patient journey, I think one thing to recognize is the NHS is designed the way it is. Years and years ago, now it's got massive, fantastic, actually, legacy and history, but it's designed in a way that is matching the funding streams.
Yeah.
And it probably is a point that might come into our discussion a number of times, is designed in that way in order to, in some ways, keep track of the system, the costing of the system, and therefore the GP, very rightly so, is in a very good position, local to the individual, and initiate a lot of the pathways, and is a central point. But in reality, that doesn't work that well. So it actually puts a lot more pressure on the GP, and therefore administration around primary care is enormous.
Yeah.
And at the same time, to a patient journey, you could be in a hospital, for example, they think you've got an imminent issue, and you've got something else that could be resolved there and then. But let's say to see another specialist, the pathway, rightly so, is we'll let your GP know. Your GP will then see you. Your GP, if convinced, will then refer you back to the same hospital.
Yeah.
to then see another specialist, for example, to maintain the sort of the funding streams. But actually to a patient, that means that's another few months. And that may or may not be a problem underneath what their current complaint, but is not clear until the next doctor see them. That's just a very high level example where the funding structure underneath the system, it takes more priority than treating the patient straight away, or in what you and I would think in another setting, actually this is now the next obvious step. Let's get this second opinion.
Of course, you mentioned the waiting times for the treatment, and there is so much documentation for it. And I asked patients around in my clinic to say, like, where do you find huge problem? And sometimes it could be right at the start. It could be access. You know, look at the GP appointment lists, right? Like, you don't see them when you actually need them. Right? Like the 8 a.m. call, try again tomorrow at 8 a.m. And by the time you see your receptionist, they will say, sorry, the appointments are gone. You know, I've got the referral to specialist services. So for instance, if a GP can't treat you and they want to refer you to something, well, that can take God knows how long, like weeks, months. I've got communication, I've got emergency, I've got mental health, discharge, and even like as simple as digital frustration. So we want to talk about digital today, but the kind of apps and the kind of solutions that we are giving to patients right now in their journey are not really designed to keep a typical patient in mind, especially like elderly people who have been used to their 0208 numbers, and you're telling them, here's a smartphone app and you can track your X, Y, and Z. So it's just failing on such a huge scale, isn't it?
I think you're absolutely right. And I think you highlight a very important point. How do you access the system? And the struggle, the challenges in doing so. So if I may, I'll just pick up on a couple of things. So you mentioned the 8 o'clock call. If you've got something, you want to speak to a GP and you really want to see them. Like now, you know, like today, maybe tomorrow, not in 3 weeks time and 4 weeks time, because by then actually the problem is probably resolved, or you found a different way to deal with your problem, or you've given up. You're just suffering in silence.
You just end up in A&E. And you literally just hog onto an appointment that could be somebody who's got chest pain or something.
Exactly that. And I think it's to unpack this a little bit more. The 8 o'clock call is actually a major topic that currently being discussed with government and contracts and with GPs. But this is kind of highlights in some ways the working underneath the system that is failing. That needs to change. So one part is many GPs would say, actually, our contract doesn't pay us to open our, let's say, request lines 24/7. And therefore, they have the 8 o'clock in the morning system, which you and I do not experience in any other setting if you want to buy or access any service. And it's a ridiculous system, because you could phone in at 1 minute to 8 and then the system will tell you your call is important to us. And you have about 50 other people on the queue before you. And then you spend the hour, you stress because you want to go to work, you have got an illness, you can't get through, and then in the end you may or may not get an appointment. Often you don't. And actually, and then yes, you're right, then you go to more extreme measure of, I'm just gonna drive down and go and sit in A&E and I'll bear the 4-hour wait, right? On the other hand, other GP groups that think outside the box and willing to adopt technology, some very successfully has opened a way for patients to request appointment online 24/7. And some report that they receive many requests out of hours. And I can see that as a working professional. Actually, and maybe by the time I get in the evening from work, I was like, this is really bothering me and I need to do something about it.
Emergency doesn't come at Monday to Friday, 9 to 5.
100%. And it doesn't have to be emergency as well, but something that needs medical attention. But some of these GPs, what they've done is allowed their patient to be able to log in online and say, can I please request an appointment, choose an appointment time, my main reason for doing so. And the technology in the practice directed that patient to the right clinician. And often the next day they get an appointment and get a phone call the next morning and say, thank you for your request. We're sorry to hear you're not well. I've got an appointment for you. How flipping that on its head can very quickly change the way it's done. But there is still the debate of our contract pays us or doesn't pay us for this, and therefore this is what we're not doing. And I am sure many people in the public would see this as just delay tactic.
Yeah.
He's just trying to push me down the line.
Yeah.
That maybe not what you want to do, but you just don't want to treat me.
Yeah. Delay tactic and also issue with communication, right? So we know as healthcare professional that there is no GP or GP surgery or doctor that doesn't want to see patient. We are just overwhelmed, right?
Yeah.
And you have major communication issues. It could just be that, how we talk to patients. So this letter sending. So, we are still writing letters and sending people, or it could just be language issues could be a problem. Think about the immigration population where English might not be their best language. We struggle there as well, or there are expensive measures. We'll talk about that too. So you said a lot of patients are waiting. The figure is 7.4 million people are currently on waiting lists for a hospital treatment.
Yeah.
So clearly, our traditional ways not working, right? So patient is frustrated, full stop, but that's not all. You've got healthcare professionals who are struggling as well. And that leads me to something that we call patient pathway, right? So for a common person, patient pathway would be that when a sick person come in with any condition in the hospital, we have a clear pathway of how are we going to seeing this person, right? So I am a HIV specialist. So for instance, if patients come in and they have been tested HIV, they go straight to the specialist HIV center. We give them appointment, we do their tests, we check their vaccine status, we check their other STD status, and then we give you treatment, then we link you to psychology, blah, 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 blah. And that happens for every specialty. So that's a pathway. Now, when I've spoken to healthcare professionals, people are not happy with their pathway either. And I know you mentioned about the contracts and funding, but what else do you see are the problems and frustrations with patient pathway now thinking about the healthcare professionals?
I think there is an element of lack of freedom in some ways to do what's right. And I think this is, it comes back to safeguarding probably finances at
Money.
the cause.
Money, yeah.
But if you're as a pharmacist and in the setting that you've described, and you come across a patient who, as you talking to them, they highlight there is an issue, right? The only thing really you can do is, okay, I'm going to let your doctor know, like basically professional to professional, let them know, etc. But it could be something that, what the solution to is actually you need to see a dietitian.
Right.
Or we need to redo this test.
Yeah.
Today, what happens is I have to let somebody else know, and probably the secretary, who then have to let the doctor know. When the doctors get a chance to look at it and then decide that this is important, they might then write the letter that takes many days, etc., etc. Eventually gets there. If there is the right, and I'm not talking within reason, within training, within scope, but as a qualified pharmacist today, and you should be able to see actually this is what you require, and I can refer directly to the dietitian. Why does the referral has to be in a letter from your doctor rather than, let's say, your pharmacist who's very much aware of their scope and can act within it? So this is, but again, come back to the point I'll try to not overdrum it, but in some ways it really is the root issue is, in order to control the system and the spend, and therefore the appointments, etc., that's why the centralized, in some ways, mechanism is the doctor will initiate a problem. Where, again, different settings today, I am pleased to see that pharmacists in primary care have have made a massive impact in the practices where they've now employed pharmacists and specialist pharmacists running specialist clinic. Oh my word, the difference is stark. That GP practice is seeing patients are being seen and treated. Their quality measures for the practice are doing really well, so financially they're benefiting. Pharmacists are enjoying that level of clinical involvement and patient contact. you could see with the right model, they're actually not necessarily costing more or spending more, but the best use of the resources that are available, you could treat patient and you could achieve better outcome.
Of course.
And therefore, we need to rethink how is our systems are designed and how do we use the resources we've got, especially manpower, which is in shortage globally, to
Yes.
the best of what they can do.
Yes.
And pharmacists, I am biased, but pharmacists can and do offer a very good solution.
Yeah.
And you and I would have heard in the last 20 years, every single changes in the bill and politics, pharmacists should do more. Pharmacy
Prescribing.
first policy.
Yeah.
Pharmacists prescribing, pharmacists running clinics.
Yeah.
And often the pharmacist perception always is, we can do more, we want to do more. Where is their funding?
Yeah.
It's always come back to that tension.
Yeah.
But I'm so pleased that pharmacists offer a solution. And now there are models that demonstrated how amazing that impact is on our national health system.
Of course. So you touched on the referral issues. So, the investigation, if a healthcare professional needs to refer it to another healthcare professional, it takes ages. Staffing shortages. I think you just mentioned that there is a global issue. I mean, boy, do we have an issue in the UK when it comes to nurses and stuff. You said the communication failure, so siloed working, GPs working somewhere else, the doctors working somewhere else, people access drugs through online as well. Talk about the bureaucratic bottlenecks, Ray. Like how, the management in the NHS right now, are they resistant to change or are they happy with their way of working? Because that, to me, in my research, comes as the number one issue, the bureaucratic bottlenecks when it comes to pathway changing.
Let me say this. Recently, our Minister of Health
West Street thing.
Exactly decided that actually in England, we need to abolish the NHS England.
Yeah.
And now this comes as a very massive topic, right? And a massive change of system. And there are both views, there will always be. And let me say this. I know people that work in NHS England and they are amazing.
Yeah.
What they do is fantastic and so important.
Yeah.
But there are so many layers in the NHS as well as. So there are many different layers of decision making. Could we simplify this today? Yes.
Yeah.
And therefore, the ethos of what West Streeting is trying to achieve with that change, big, bold change, I understand it will come as major surgery to the NHS system. My only sort of challenge with this is, can we quickly make the changes and what is the new world should look like? Okay, by all means, dismantle current system, but dismantling current system with that absolutely being clear, what are we trying to achieve and how long is going to take us to see then positive impact on patients, that's unclear to me. So you're going to pull the rug, okay, and then what? I think, so now what's coming out is the integrated care boards that hold funding and responsible for population health in local areas. Okay, they're now going to be changing the way their responsibilities will change. Okay, well, who's going to do what? Oh yeah, their responsibilities will be, some of it will be handed down to more local level, GP groups, etc. Nice idea. But today, our world today is, NHS England is advising the ICBs what to do.
Yeah.
The ICBs know that their role is going to change and they're going to devolve some of the responsibilities more locally.
Yeah.
And therefore, none of them are taking accountability today.
Yeah.
And I know this is a harsh statement to say.
No, that's fair.
But in some ways, what you're saying is that these parts of the system are going through major change, which mean there will be hesitation if in any marketplace, if you making big changes like that. My worry is, well, where is patient outcome today and where are the changes? So to answer your question, I think NHS managers do a ridiculously good job. They work so hard. Their constraints, I think, are massive as well as. But we are about to enter into a phase, which I think necessary, of changing big element of the system where it doesn't work well. But I fear that this just goes through a cycle of political realm. And then it's just to keep the government entertained, do what they think is best. but will cost money.
Yeah.
But if it doesn't achieve anything tangible, that would be my problem.
Yeah.
And our problem as a nation if the outcome is not clear.
Yeah. I read somewhere about the NHS England. I'm forgetting the year when it was established. But what I read was that over the years, NHS England has expanded in terms of workforce like crazy.
Yeah.
And their budget has expanded force like crazy. But when you look at the healthcare outcomes,
Yeah.
it's not correlating.
Yeah.
Right? So it's not that we are dissing NHS England to say that they weren't doing the good job, but the point is that it needs to be measured. Like if you're expanding, it needs to be measured to something.
Yeah.
And the only thing you should measure it, I think, is taxpayers' money and your health outcomes.
Yeah.
And the thing is, they're all going up with the NHS England's workforce going up, but it should be the other way around.
Yeah.
So, I mean, something needed to be done. But yes, we are surgically trying to cut it. Execution all depends on execution. And I do feel like ICBs now actually have much more work to do. And how is this going to work out will be very, very interesting to see.
But this comes to how these organizations think in how best to get the best outcome that is long-term view with short-term. Short-term is today's problem is we are way out of budget, we can't deal with what we need to do, etc., etc.
Yeah.
And that is what generating or fueling the waiting list that you mentioned.
Yeah.
Given a separate way of thinking is how do we get the best outcome and invest in the long term.
Fair.
And that requires all the different departments within our health system, our amazing health system, to work together for that best outcome. But if everyone is in it for their own problems today, sometimes fighting for their jobs today, it means actually our eye is not on the outcome that you mentioned. Our eye is on today's problem, my problem. That could be a disaster in the short term,
of course,
and delays us achieving our outcome in the long term.
Fair. So this was NHS, right? What we just discussed. I think it was a very lengthy, fruitful discussion, I would say. Now, some people might be listening to this and thinking, well, that's NHS. What can you do? It's overwhelmed. Surely private healthcare is much better. Surely if I had money to pay for this issue, it would all go well because somehow private healthcare, it just looks like a nicer hospital. People get better food. Now, you have worked in private healthcare as well as a healthcare professional. So compare NHS to private now and tell me first, what are the advantages, immediate advantages of working in the private healthcare, and what are the challenges?
Yeah, I think I'll answer your question, Abby, but probably just before that, I just want to say something that is, I think it's helpful for us all to think about private healthcare not as a competition of the NHS. That's not the case. It's actually both the NHS and the private health sector together is our healthcare system in the UK.
Important,
And I think that's really, really important. And each play a very important role. And I'll answer your question around where the advantages are. But I think I just want to make sure that we're clear about that point in some way. So it's not a competition. And I think it'll be very hard to compete with the NHS. Globally.
Impossible,
right? Because it is amazing in so many ways. But we've described some of the kind of the flaws and the budget side of things, which then causes delays.
It could be better,
Private healthcare, the advantages, and you nailed it on the head earlier on when you referred to accessing the system. The number one advantage of a private healthcare is system access, which means I can phone now and say, I would like to see a GP, and I'll have a GP available. I'll find somebody, right? The immediate drawback is that's not my GP who's known me, might not have all my information immediately. So if it's something simple, relatively speaking, I can speak to a GP now, get the answer, get a prescription, sorted. So let's say your 8 a.m. call scenario is irrelevant. In fact, you can do that out of hours as well, as I'm sure. You can find doctors to do that. If it's very complex, well, actually, not all, and I'll be very clear about that, not all private hospitals are suited for very complex care.
Of course.
Some are,
Of course.
and some do it incredibly well.
Yeah.
And I've had the privilege in working in some of these organizations that are very well, let's take a cancer care, for example, having the best consultants who I have to say almost all of them are NHS professors, etc. So available best treatment, good caliber pharmacists, specialist nurses, intensive care support, you name it, 24/7, you name it. So these exist, but not every hospital, private hospital, is able to deliver that level of complex care.
Right.
So the majority, and where private healthcare in many parts play a very good job, and probably you would have seen it a lot in the papers recently, let's say cataract surgery.
Right.
Orthopedic surgery.
Yeah.
Basically, surgeries that are needed in our society en masse can be very well done. And when the funding systems is done differently, so either is NHS outsourced to a private operator to do the surgery, or self-paying patients paying for it, or patients who's got private medical insurance and getting the hip replacement or knee replacement privately, the expectation then on the hospital is they're a commercial organization. Often they are for profit, but not all of them as well. But their intention is more, how do I do this very efficiently, very quickly, give the patient the best quality, and look after them in their stay, so the nice room and the nice food, so that they have a very good lasting experience. So when they leave, they think, you know what, I've had a really good experience, and if I need to go back, this would be my hospital of choice.
Yeah.
Right?
Yeah.
So that's kind of where it's done. And because the funding system with the private sector is different,
yeah,
they're more caring about the outcome.
Yeah.
I want this patient to get their outcome, health outcome, as quickly as possible. And therefore, if I walk today into a private urgent care center seeing a GP, essentially, they'll be like, well, we could be these 3 problems. So why don't we do a blood test, do the scan, and let me examine you. For example, you could get results within 15 minutes because these places have put systems in place to be able to get a scan quickly, blood results quickly. The doctors see you back in half an hour and say, right, here is all the results that we've got. We think this is the issue. You now need to see this specialist. If you want us to help you with seeing that specialist, the reception will book you, and it'll be like, I've got an availability tomorrow to see the specialist, or this afternoon because he happened to be here, or she's happened to be around tomorrow. Let's get you booked in. The outcome is in sight.
Yeah.
Rather than all the different journeys that we've been referring to earlier on. So I think that's the incentive is on the doctor to actually get to the bottom of the issue rather than do things in parallel rather than in series.
Yeah.
And I think that's where sometimes in NHS, it does take that little bit longer.
Yeah.
I give you a small example, if I may.
Yes, of course.
So this is based on a real scenario. A patient has gone to see a GP, eventually being referred to see a specialist for indigestion problem, stomach problem. And essentially, there's a number of potential intolerances to foods or products that we probably need to test for. A traditional NHS journey would be well, let's do test number 1 first.
Yeah.
And then do test number 2, and then do test number 3.
Right.
So test number 1, you need to see, let's say, a dietitian. So we'll book you appointments, few days, come back, do the test, few weeks, get results, go back to the doctor to follow it up. That's not the problem. Let's do test number 2. You do that, and then test number 3. In reverse, in private, they would say it could be 1, 2, and 3. Well, let's do 1 and 2 and 3 now.
Right.
And then let's check the results.
Right.
Now, the difference is, well, if I do 1 and 2 and 3 now, the cost is almost upfront.
Yeah.
So everybody will be like, understandably, well, this is going to cost a lot. Actually, the fact that we've got to the point very quickly, there isn't about 50 other appointments that we didn't need to do. The patient problem has been resolved quickly.
Yeah.
And therefore did not become even worse.
Yeah.
Requiring more expensive, more involved
Because I think
treatments.
private understands that time is money,
Yes.
you know? So I think everything that you said, I had it on my list: shorter waiting time, more time with consultants, better services, flexibility, convenience. What are the challenges in private care
Yeah.
if it's all so rosy?
It's I have to say it's not perfect
Yeah.
by any means. I think one biggest issue is that fragmentation.
Yeah. Yeah.
So private healthcare is fragmented in a different way than our NHS system is fragmented.
Right.
But and this is one of our biggest problem in the health service in the UK, whether it's NHS or private. We don't have all of our data in one place, and therefore is much more difficult to navigate the system sometimes. So give you a very simple example. So I've seen a private surgeon to do my knee replacement.
Okay.
They have to do an MRI.
Yeah.
Right. So they send me to, let's say, in the same hospital to get the MRI. They have the results in there. I could request to get the information, copies of the MRI, but often that's more difficult to obtain. Now my GP doesn't have a record of it.
Yeah.
And now I need something else.
Yeah.
In some ways, what the system will force then the next clinician to do is to order another MRI.
Yeah.
Right. And these are kind of, and then now my records, some of it in that private hospital, some of it with my GP, some of it is now with the new MRI scanning department in another hospital. So in terms of where our data and our medical records is fragmented, and this is one of the advantages and the things that I've seen working with Axonic Health, actually rethinking where does the medical record need to sit.
Yeah.
It sits with the patient.
Yeah.
So if I am an Axonic patient, all my medical record sits with me.
Yeah. Yeah. Yeah.
And therefore, if I am abroad, if I'm in a new hospital, I can share with a toggle my information with the new hospital doctor. So then they've got all the information.
Yeah.
That's where I think the fragmentation is an issue. And if you're looking at, let's say, London private hospitals, more often than not, they are amalgamations of different buildings within a few streets far apart. So not far, but actually you've got to go from one building to register to the other one to see the doctor, to come back to pay in another building. So that not being in one place often is a problem. Cleveland Clinic, for example, is a new private hospital that came to the UK, but on one big site. So it addresses some of those sort of fragmentation in some way. So they've got all their one records in one place, one building, maybe a small issue, but if you are a patient who's not well and you're having to trot between different buildings, might not be as easy.
Yeah. So it seems to me that both of these systems, NHS and private, are somewhat interlinked, but one is not the fix to another, right?
Yeah.
So what we've established so far is that we have patient who is unhappy, waiting times and not getting the outcome they want. We have the providers, healthcare professionals who are not happy because the pathways, and we also have the government who's paying for all of this unhappy. If you look at the Lord Darcy's report, he said NHS is in critical condition. NHS is on life support. If you see what Sir Keir Starmer, our Prime Minister, said, that NHS is broken, right? These are the government's word. So the patient's not happy, the healthcare professionals are not happy, the government is not happy, but we all share the same vision, which is healthcare needs to be reformed, right? We all share the same message that healthcare is a human right, right? So to me, this sounds like a perfect industry to be disrupted by modern tech, by AI. And it just so happens I have a health and technology strategist sitting with me. So let's talk about solutions now. And if we're talking about technology, where do you see technology and AI making up a real difference? And let's go through patient journey, and then we can talk about patient pathway.
Sure.
So patient journey, where do you see tech making a difference?
I think patient journey, I think that makes probably the low-hanging fruit when it comes to the application of modern technology with or without AI, but I don't think today we can ignore AI and what the impact that is doing.
You can't.
And I'm pleased to say that today some organizations are embracing it and are seeing the benefit. So to give you an example, I think if our new world that is open to the application of AI and technology system, very quickly as a patient, I have all my records.
Right.
Any new appointments that I'm getting have access with my consent.
Yeah.
So you could very quickly take away a lot of inefficiencies in the system or redoing tests because the information is available
Yeah.
when you need it.
Yeah.
Right? When you're talking about access, if technology enables me to make an appointment with the right specialist at the right time in my own language, preferred language, then very quickly I am being seen by the right specialist and I'm getting the help that I need very quickly.
Yeah.
And I understand it, and which means I can comply with it.
Yeah.
Which means I get to my outcome sooner. So on the logistical administration side of things, you could see an enormous benefit. Think about every call center that you have to call into. If I don't have to do that, or when I need to speak to someone, they're not dealing with 1,000 calls because they're now only dealing with the 20 that matter.
Yeah.
Then I'm getting the human touch where I really need it. And I need to speak to somebody, I will speak to somebody. If I am, like my great grandmother who not on the phone, not on the apps, but need to speak to someone, then yeah, they've got that availability and access to do so. So you could see logistically that could make a massive difference. Taking away the letters to make an appointment. I receive letters weeks after my appointment is come and gone. What's the point?
Yeah.
Nowadays, if everything electronically available can be available in another language, can be translated, can be printed in large size, can be spoken, technology can support all of that, which is the other part that, if I may just highlight this, new technology will help us more than ever to reach our parts of the population that are very hard to reach, and where parts of our population get inequality of what's available to them because of their location or because their language barrier or because their social exactly. Where technology can actually break a lot of those very quickly and very easily. So why wouldn't we?
Ray, take a guess. How much does NHS spend on translation every year?
It's an outstanding number. I have, give me a second. I think I remember looking into that. Was it 150 million?
Yeah, I mean, definitely close to 102 is what I have. This is an article from Daily Express dated from April 2024, where through freedom of information laws, they asked 251 NHS trusts and 42 ICBs to reveal their cost of translation services for 2021 and 2022, and collectively it was over 100 million pounds, which could pay for 3,000 nurses.
So, Abby,
Crazy.
Huge amount of sum, right?
Crazy.
Over 100 million. But let me put another point to that.
Yeah.
That's the direct cost.
Right.
So think about it this way. So some of these services offer translators that get booked to arrive to be with the patient if they have a consultation. Say, right? To translate to them. How many times do the translators do not turn up? And then the appointment with that consultant or the
it
scan
had to be cancelled.
It doesn't go ahead.
Wow.
And gets rebooked.
I didn't think about that.
See, that's one example, right? There are probably other indirect
costs. Yes.
The way I say this is I've been in a scenario where this happened, but actually happened the other way around. Somebody on the phone decided that a patient needs a translator. They didn't need it.
Yeah.
So they booked a translator. So the translator turned up and they were like, "Why did you turn up? We don't need you." The nurse was like, "Why did you book a translator? We didn't book a translator."
Crazy.
So basically what I'm trying to say is there will be some, I don't know, I can't quantify it for you, but there will be some that a patient doesn't turn up. And we know patient DNA rates in NHS, I don't know, actually, I don't have a figure for it, but at a guess, at a conservative guess, I would say is 7%, 8%. Realistically, it's probably 30,
more. Yeah,
right?
yeah,
But
yeah.
let's say even 10%. 10% of the appointments, the patient doesn't turn up. So 10% of appointments that need a translator, for argument's sake, then doesn't go ahead. Then they need to rebook. Now you add in another element of the translators themselves not turning up, or confusion in the booking, or double booking, or any of those administrative matters. That 102 million that you refer to, realistically, is a lot more.
It's a lot more. Yeah, yeah.
And also, I remember looking into this. Not all trusts and in other areas were that easily able to share the information or have the information to share it.
Of course.
So what you've got is those that could share the information
Yeah,
because
yeah,
they
yeah.
knew about it. But is a massive sum. And again, I would know some politicians went on the news media saying, let's treat people with let's not treat people that can't speak English. I mean,
everybody should learn English.
yeah, which I love the idea.
It's
However, well, actually, no, that's not my approach. Would be
real
this:
world. You gotta
why
be.
don't we use technology
Yeah,
that is available today
yeah,
to press a button and
yeah,
speak the right language and get the appointment done when it's done, when the
yeah,
patient is there?
yeah.
And you can imagine, even just on how many gases that we going to save in our world, because all these translators don't need to drive to appointments and so on when technology can take place.
Of course. I actually couldn't agree more. When I see the politicians talking about everybody should learn English, it's like, well, 3 million expats are sitting in Spain right now. Imagine if they say, speak Spanish or you won't get fed.
Yeah.
Speak Spanish if you
Yeah.
don't, if you get a road traffic accident there, what are they going to do? But, anyways, we're not getting political.
No.
Going back to tech, Ray, now, the two constant themes where we can make a huge difference is data
Mhm.
and time. So data would help patients massively. Well, it will help healthcare professionals massively as well. But generally speaking, patients want access to care, but healthcare professionals say, oh, it will save me time. So think about data and then you think about time. What's something you've seen in the tech world that you are really excited about?
I mentioned briefly about Axonic Health.
Yeah.
So Axonic Health looked into how to look at patient journey and the challenges in the health system, and how does data mobility resolve a lot of these issues. So translation as a function is available with a click of a button because the technology is there.
Yeah.
As an example,
Yeah.
that's 100 million
Saved right there.
at least, just
Yeah.
like that.
Yeah. Yeah.
Appointments, the ease of appointments,
Yeah.
the availability of capacity. So if you look at a system and you can see, where do I have appointments, where do I have demand, and how do I shift, just by looking at the data in the background, that is enormous. I think so that this is on the time saving, but imagine then if we save our clinicians even 10% of their time,
Yeah.
so that they're not writing letters,
Yeah.
because the system can do that for me.
Yeah.
And we can give them time back because the system can take drug history, can take medical history, can summarize it, can translate it.
Yeah.
Can advise me as a doctor, says, by the way, did you realize the patient is on these drugs, so you can't do this, or you got to be cautious with
Yeah.
X, Y, and Z, the precautions.
Yeah.
Support. Or it could advise the doctor, say, you could consider these tests, you could consider these, and the doctors does make the decision. Then we're making the doctor even more powerful.
Yeah.
And again, is giving that patient the best possible outcome and consultation and informed discussion, so that they can make a decision that is best for them and for their condition. So on the logistical side, and the time saving is huge.
Right.
And Axonic Health, you could see how that is being done incredibly well. On the clinical side, there are many other systems that are happening today, and I just want to touch on this very briefly.
Yes.
Today, our data and data mining that is built into our systems, like, for example, breast scanning for breast cancer, it's routine now that the system will double read the scan, like another radiologist.
Second opinion.
Second opinion that is already there. That is an area that is growing quite a lot. There are other companies that I was talking to that will do lung screening to determine, essentially look for lung cancer, which at the moment in the UK, I know there is a new shift to screen for lung cancer like there is for breast cancer, but we're so behind the curve because lung cancer is again one of those areas where by the time we discover them is almost too far.
Right.
So if you do the screening and we have technology that the data can read tens of thousands of scans very quickly and highlight anomalies that support the radiologist very quickly, that makes a massive difference.
Of course.
But also it means that doctors are spending more time with the patient rather than just chasing scans. So there are big advantages, and catching a disease early is, of course, we know that outcomes will be much better for patients.
Of course. I interviewed the founder of Axonic Health. Thank you for hooking me up with him. And in an hour I spoke to him, there was one analogy that really stuck with me. And I used to wonder about this whole data problem. There are 7 billion people, everybody has health issues, everybody's accessing care so fragmented. How are we going to fix the data? How are we going to do it? It's impossible. That's what I thought. And then he gave me this analogy of comparing healthcare with finance. And he said, I'm paraphrasing it, but he said that healthcare is where finance industry was 50 years ago. And now the finance industry is so clever that you could be in America taking out $10 from your debit card, which was issued in the UK, and within a matter of seconds, it will show on your bank statement that you're in America and you've taken out $10. So the technology exists to bring the data together so much that in real life you can see the change. And that really blew me away. Because imagine you're in Spain. I don't know why I keep going to Spain, but my mind.
Lovely place.
But yeah, I need to go back. But the thing is, imagine if you have, God forbid, some chest infection in Spain and you're a UK resident and you go to the hospital and there is something, like right now we have a debit card that tells us this is our bank detail. But let's just say you have an app that is telling you that you're allergic to penicillin. And there is some Spanish system where they can just scan it and then they get access to all your data. That could be life-saving.
Yeah.
That could be time-saving. That could be so efficient. And the funny thing is that all of this exists right now after speaking to Dr. Tripada. That really blew my mind to say that, why is it that when we have the solutions right now, but the adoption seems to be not really taking the pace as it should be. So if you're the decision makers within the healthcare, what do you see are the biggest barriers within the organizations to adopt these techs?
Yeah, and I think it's a lovely concept that we've got all this technology today, but how do you actually bring them into real life?
Yes.
I think one thing that, and in a sense that you've had a fantastic conversation with Dr. Chapada, I think is thinking about the data in a way that, or if I put it another way, the interoperability of the systems between the different parts of the system. So let's say the NHS hospital, the local pharmacy, the NHS GP, and let's say the private hospital that did the scan. So how do these different parts of the system talk to each other?
Yeah.
That's the interoperability.
Yeah.
And that's where the data flow between this organization is so important. So in order for that to happen in a sort of in a global scale, it needs to be an agreement high up enough in the system that somehow enable all these systems to talk to each other. Now, few years ago, systems interfacing with each other was a big thing. Today, AI can do this very easy.
Absolutely.
So even that, the connections, so if you have all the agreements in place, you just want to do the technical connections, it was quite involved and you have to do it carefully, ensuring patient safety, good processes, etc. But now you could obviously need to ensure all of these things, but it can technically be done a lot faster and a lot more accurate in a very safe environment. So it comes down to a decision of making it happen.
Yeah.
And how is that going to be linked? So this is number one problem is it needs to be high enough decision that brings all of this together. So you would remember, you and I, the NHS spine would have been created at times when we were on the wards as a pharmacist.
Yeah.
But you and I would have spent, I would say, 30+% of our time as a pharmacist on the ward, if not much more, trying to ring a GP to get a drug history so then we can treat a patient.
Oh, these
Right?
young pharmacists do not know what we dealt with.
Exactly. This is almost like trying to teach my kids about tape players and wind up with a pencil and flip them to get the next song. It's that was the system then. But today, why don't we have an expansion of the current spine that is available in NHS in a summary form to anyone who is providing care in the UK?
Yeah.
You know, why is it that a private hospital that is on the market, quality assured, etc., doesn't have as easy access to that? Because when the patient comes in, that's important.
Timing
And we could
matters.
manage
Yeah.
and we could manage consenting in a very good way, etc., But the local pharmacist, so if I walk into a pharmacy asking for advice, even on something over the counter, it would be good practice. Say, give me a second, let me have a look at what your medications are. Of course, you can ask them. But if I can see it, you and I, as a pharmacist, will see, yeah, we know the detail of that, and what you're describing may be something else completely different.
Can I give you an example?
Of course.
So I'm a HIV pharmacist, right? Hay fever season. What's the first line treatment if you go to a pharmacy and you say, oh, I've got symptoms, you get nasal sprays,
Yeah.
right? But a lot of people don't know nasal sprays have steroids
Yeah.
in them. And the top most selling brand of nasal spray is contraindicated with some of the HIV medicines.
Yeah.
Now, people don't ask on the counter because of confidentiality. But what you're saying, that if that pharmacist had access to the spine, which is spine is basically a system, a software, you know,
Yeah.
the healthcare software. And if the pharmacist had access to spine, he could see it and he doesn't even have to ask any questions and say, hang on a second, I can't give you this. You can take these tablets or
Yeah.
something.
Exactly.
Right? It's such, I mean, that's the example that came into my head.
You could almost take that a step further, that if you've got technology within your pharmacy system, that is, and you've got the system has access to the patient summary care record, not their whole life, but the important stuff. And let's say that you're about to sell them that nasal spray, and you scan it. You scan it as you're selling it. The system could very quickly highlight to the pharmacist, you need to check this against the medical record. So even in that very basic example, you don't need to check every single patient's full medical records every time they buy something over the counter, but the system can very quickly notify you if it needs your attention.
Of course.
So you look at this in a way that it is efficient, but we don't miss a thing anymore.
Exactly.
You know, or our level of errors as humans within the professional healthcare sector can actually be way reduced because of the use of the technology.
Yeah, I mean, I really do struggle to understand that we have systems right now that can save healthcare professionals time. We have systems right now that can improve outcomes. We have systems right now that can make healthcare professionals' life easy
Yeah.
and free up a lot of time. But whatever it is, bureaucratic red tapes or lack of information or resistance to change, I think all of that really we need to just put this aside and try and see that, look, nobody's happy, but
Yeah.
everybody wants to be happy, and this is a solution.
Yeah.
So you can cry about it, or you can complain about it, or you can do something about it.
I mean, Abby, one of the other advantages in the private sector is there is in some ways, the autonomy. There's probably access to funding, and most importantly, the desire to achieve more in terms of throughput, treatments, etc., to increase revenue, but also to improve the working lives. Give you an example. You would have seen in the news recently a lot of private companies that do eye surgery.
Yeah.
And there was positive and negative kind of comments in the papers that I'm sure our audience would like to go and explore further. But the point I want to make is, because the NHS have outsourced a large volume of cataract surgery, it attracted financial institutions to invest in centers that focused solely on eye surgery. What you and I know from practice, if you are an organization, NHS or private, that focus on one disease area, you become very good at it because you've got the mass, you've got the volume, you have basically, you develop methods that will improve outcomes.
Yeah.
Today, I know some of these organizations, and I've discussed, especially the technology side with some of them. They've improved patients' pathway using technology. So the booking systems to get surgery is amazingly done. A lot of it by technology. The preparation before surgery is done by technology,
Wow.
which means that hardly any patient missed their surgery, and they are very much aware of what the surgery is about. The surgical time is being finessed so well that it's super efficient. So then you're maximizing the very expensive engine room of every hospital, which is the theaters, operating theaters, and then patient leave with support. A lot of it is technology enabled, where patients can access information about side effects, about recovery, etc., etc. And the throughput has been outstanding.
Wow.
So they've managed to reduce their cost of doing the surgery. So they're making more profit.
Makes sense.
One part, which in the news, you could see how would that be a Daily Mail and other papers headlines. But on the other hand, more importantly for patients, they've also improved the quality outcome.
Satisfaction is up. Yeah.
Satisfaction is up, but clinical
Outcomes is
outcomes
up.
are up
Yeah,
as
yeah,
well.
yeah, yeah.
And they've published that.
Yeah.
So you couldn't really go back and say you're a cheap, or just private, you're just making money. Actually, if you structure it well, you could reduce the cost of delivery. You could improve patient outcome, and most importantly, patient satisfaction.
Wow. Wow, Ray, I can sit here talk to you for hours, but
I think we can.
I think we can, and we will. We will again. But I just wanted to bring this message home that there are two ways of looking at the current condition. One is a pessimistic view to say that everything is crashing, nobody's happy, outcomes is this, mortality is that. And then there is a very optimistic point of view, which is that actually, yes, things are bad, but this is a time when the best innovations come out because necessity is the mother of all innovations, right? And you are at the forefront of it. So I'm going to ask you two more questions. If any of the healthcare, the key decision maker people are watching this, what is the one message you want them to hear?
I think a basic one is invest in technology at pace.
Yeah.
I think, and be bold.
Yeah.
I think that's an important one. I think a second one would be is involve your clinicians as part of your decision making.
Excellent. Be bold. Okay, last part of this podcast, Ray, I call it Dose of Health. And I ask this question to everybody. So I'm going to ask you as well. If I give you a magic wand called Dose of Health, and you can wave it and change one thing in your field immediately, what would that be and why?
That would be, I think, the way we adopt new technology. I think, because to me, I know and I can see how technology will change our life, but more importantly, will reach patients and parts of our population that is beyond reaching that access of information, access to health. And I think technology will definitely help us to reach them and provide them with healthcare.
Amazing. Every life is worth saving. Every healthcare professional is doing a great job. And I think we should really push all the solutions that we have to try and accelerate that. And I think tech is one of them. And that's the message we are trying to give our audience, your audience today. And I hope people hear it. And I hope people come and talk to you about the solutions that you are heavily invested in. Where can people find you, Ray, if they want to get in touch with you?
I think the best way to do so is to find me on LinkedIn.
LinkedIn.
Otherwise, my email, I'm sure we can put it on the screen.
Yeah.
I'll be delighted to have any conversation and explore any of those ideas further
Amazing.
with.
What I'll do
And
is I'll actually put your LinkedIn address in the show notes so that people would be able to contact you, you know?
That'd be amazing.
Great. Thank you so much for your time.
Thank you, Abhi, so much
Amazing.
for amazing discussion.
Great.